Hi, I'm Dr. Janet Pope at Room Now, reporting on the virtual ACR 2020. Welcome to Washington or wherever we all happen to be. So, I'd like to talk about number 1825, and that's looking at risk factors for antimalarial retinopathy. So, between EULAR and ACR, there have been a lot of abstracts looking at the safety of antimalarials, including not prolonging the QT interval, but also in looking at the safety of antimalarials with respect to retinopathy. There are new guidelines over the last few years that we should dose 5 milligrams per kilogram per day of actual body weight or less of hydroxychloroquine to decrease retinal toxicity. So this study, and I am one of the authors on it, so true disclosures, we wanted to look at retinal toxicity and to find, would it be different in SLE versus other treatments such as rheumatoid arthritis, adjusting for confounders? How common is it? And is there a dose or a time response? So the first thing was, it does appear that comparing other groups of patients, that lupus has more retinal toxicity. Maybe it's adherence, maybe it is because we use it for longer, but when we adjusted for duration of use and dosing and body weight, we still found this to be the case. The next thing we wanted to look at was, is there a time frame? So some guidelines recommend that you don't do your eye exams until 5 years and beyond. In Canada, we tend to do annual retinal eye exams with visual field and also often a retinal photograph or CT of the back of the eye. What was found was that there was virtually no proven retinal toxicity before 5 years. So I think that that is still a safe dose. The final thing that we found was that confirmed or suspected dose retinal toxicity was not necessarily increasing with time or dose. There was a hint, but when we adjusted, it really didn't come out. So there's probably a threshold above 5 years where some retina are at higher risk than others. The final thing, and this has changed my practice, is that the patients using chloroquine instead of hydroxychloroquine, routinely dosing at 250 milligrams once a day, had the highest retinal toxicity. And it was very sobering. And fortunately, while we were doing this study, there was a shortage of chloroquine in Canada. It's on permanent back order, and that's even before the COVID-19 thought of using chloroquine or hydroxychloroquine. Therefore, I did change all my patients from chloroquine to hydroxychloroquine. And if their rash, it was often cutaneous lupus features. If the rash was worse, I actually would end up using other background immune suppression. So I will not use chloroquine long-term anymore in any of my patients. Thanks for listening. This is At Room Now, and enjoy the rest of ACR 2020. Thank you.